So hi everyone, welcome to this season of the Allied Test and Discussion. The first session, of course, where we start with pediatric rheumatology. So whenever we start off with an allied season, our aim is to get our efficiency or efficacy as best as possible, and by that I mean like whatever hours we are conducting the allied for. I think around about 12 hours. We're conducting 11 to 12 tests and we're doing it around about 1.5 hour each. So inside those 12 hours and around 250 questions, we want to get maximum topics, at least if not the questions. I don't think questions repeat is easy to get in any NEET SS pattern, but at least the topics should repeat. The last time, the recent NEET SS 2024, we went back to our Elite season 2 and season 1, and there we noticed approximately around 60 questions that came from the Elite. And I think I'm talking about the topics. For example, if HSP clinical feature was asked and clinical scenario was asked, and we did discuss a clinical scenario, that kind of topic repeat was around about something like 40%, and I think that was great. And I think that is our same thing that we want to repeat. And because of that, we mainly haven't gone into anything like complicated questions, controversies, very in-depth questions. We want to kind of double down on the repeat topics, because that is again repeated, that is very common in any exam. And also we want to give you an information about certain weird questions that have been repeated, so any that have been asked before. So any particular weird question that has been asked in the NEET essays, I have kept that, because that is something that you might think that it is not important and get missed. That is one criteria. And anything that has been repeated multiple times. So these are the main questions that have been kept in each elite. And then obviously there are some topics which are important by default. Those are also we will be discussing. So pediatric rheumatics is around about 8%, so that makes it 1/12 of the portion. And it's, I think, fair enough that we give it one elite series, one elite session. But the questions that come are usually restricted to certain topics, so it's kind of easy to read, and you can say scoring as well, right? So we go on to without further delay each question. So this is an interesting question, because there is one place where you can get confused, and understanding the definition of each type of GI is very important. Because what is happening here is, initially the patient was oligoarticular. So oligoarticular means less than equal to 4 joints, right? Less than 5 is oligoarticular. You can just remember, like poly is in Hindi we say પાંચ, so P for P, and 5, from 5 polyarticular starts, right? So oligoarticular is less than equal to 4, and that was how her initial presentation was. And later, however, at 4 months of after the symptoms started, at her current visit, which is 4 months later, now examination reveals in multiple joints, in both wrists, elbow, and the older joints. That is 5 joints that are there: right knee, left ankle, both wrists, and left elbow. That is 5 joints have gotten involved. So the main confusion here is it extended oligoarticular or polyarticular? So the main thing that you should remember is the cutoff. So 6 months is the cutoff where you can call a child to be oligoarticular GIA. So after 6 months, if the same oligoarticular thing persists, then you call it as persistent oligoarticular. And if initially it was less and after 6 months it became extended, that is more, it became polyarticular after 6 months, then you can call it as extended oligoarticular. But within 6 months, if the patient is becoming polyarticular, then you will call the patient as a polyarticular GIA. So this, and obviously RF was negative, so RF negative polyarticular GIA is the correct answer here. And another important point is, firstly, the 6-week cutoff that we take for definition of GIA or classification of GIA or diagnosis of GIA, you can call it. This is also fulfilled here. That is also another important point. For example, if this was, if we were talking about 4 weeks and the patient came at 5 weeks, then we should, all of these are not exactly correct, because GIA cannot be defined itself, right? So here the main thing that you should remember, two cutoff, 6 weeks and 6 months. That is what was being tested. Obviously, we're not going into in-depth of each type. That is beyond the scope of this short session. But RF negative, what should you remember about it is bimodal, age distribution is bimodal, and depending on the age bracket where the patient is presenting. For example, here it's a 10-year-old girl, so that will have a 10:1 ratio or a 9:1 ratio with respect to female male ratio. And another important point is the it is not very much symmetric. Large joint, for example, in RF positive, it will mimic like a rheumatoid arthritis. That is small joint involvement, bilaterally symmetrical, upper limb, lower limb. But here it can be asymmetric also. It can be symmetric, but it can be asymmetric also. And TMJ involvement, cervical spine involvement can be there. Otherwise, uveitis can be there. For example, in RF positive, uveitis is very, very less. Systemic onset uveitis is very, very less. RF negative uveitis is possible. And apart from that, treatment is standard, more or less similar to your RF positive RF positive GIA that is there. Next is your very recent question. I think all of you should know this NEET SS 2024 question. One of the difficult questions, I would say, in your pediatric rheumatology parts. So here what was asked was not just Kawasaki disease, the classic Kawasaki disease, the fever and the crash pneumonic, which is there, conjunctivitis, rash, adenopathy, strawberry, mucosa. This is the mnemonic, right? So, and the hand foot changes. So the mnemonic is crash, and along with crash you need fever for 5 days, along with 4 out of 5 of crash. That is the definition for a classic Kawasaki disease criteria. But here you have an incomplete or an atypical Kawasaki disease. So what do you do in that? So this has been given nicely in your Nelson with a proper table, and the question was asked from there. So epidemiological or classic case definition, I've already told you, fever for at least 5 days plus 4 out of 5 of this crash that is there, right? So now we have atypical or incomplete KD. Incomplete or atypical KD, you have fever that is there, but not enough of these 4 out of 5. That is either 2 or 3 manifestations may be there, or it may be an infant. What happens in an infant is it presents a lot of times with like a PO, not even 4, not even 3 may be there of these hand and foot changes, peeling, etc. Right? So in that particular case also you have to be wary and always think about atypical Kawasaki disease or incomplete Kawasaki disease. So what do you do? So you have a suspicion. So that is the first and foremost criteria. You should have a suspicion of, for example, in our previous Nelson edition, what was written is, after going here, you should was written that do you have a suspicion of KD or not, and then if yes, no, all of that was written. They have removed all of that from this table. They've kept it much simpler. If there is suspicion of incomplete Kawasaki disease, then only you go forward. Then you see, is it a child or is it an infant? If it is an infant, you have a little more suspicion, higher index of suspicion, or a lower threshold to work up in this particular line. So firstly, you see lab tests. By lab tests, what do you mean? Firstly, you see the inflammatory markers, that is CRP and DSR. If the CRP and DSR are high, then you have an even more added evidence that yes, this is possibly a Kawasaki disease. But if you do not have, then you go to a lesser, milder workup route. So what is a milder workup route? What do you mean by milder? That is, you can say, okay, we are not very sure that this is incomplete KD, right? So when the inflammatory markers are less, both CRP and DSR are less, then you just do serial, monthly evaluation of clinical and lab evaluation like CRP, ESR, especially if the fever persists. If the fever has also gone, then no need to keep evaluating. Now, if peeling starts, that is, peeling is basically your periungual peeling, then you go for echo as well. That is with respect to if the inflammatory markers were negative. If the inflammatory markers are positive in a suspected atypical KD, then you will work up. What workup? That was what was asked here. Will you work up for ferritin? Will you work up for anemia, albumin, all this? So firstly, easy to remember all the CBC things. Anemia will be there, thrombocytosis will be there, leukocytosis will be there. And after that, you do 2 things in the blood and 1 thing in the urine. In the urine, you basically see sterile pyuria, that is your WBC more than 10 WBC per high power field. And in the blood, you see 1 in the liver, that is a transaminitis, increased ALT, and the other also from the liver only, basically, that is albumin, hypoalbuminemia, and transaminitis. And remember, it is ALT, that is liver specific things we are seeing, right? So out of these 6, you need at least 3. If these 3 are there, then yes, you can treat as a atypical Kawasaki disease. Or in some particular settings, you can even do an echo as well. If you have an easy access to an echo and you feel that you should rule out coronary artery aneurysms, you can do echo at this stage as well. And if it is a positive echo, then obviously you will treat the child. So that is how you will basically evaluate for an incomplete KD. So here ferritin is not there, hypoalbuminemia is there, transaminitis is there, that is ALT elevation. Blood is there in the form of anemia, thrombocytosis, leukocytosis, and sterile pyuria is also there. So with respect to drugs, there was a previous year question with respect to your NSAIDs dose. NSAIDs dose, even the dose amount was asked, but here we are talking about biologicals. We're not talking about NSAIDs, and we are talking about the frequency, dosing frequency, because dosing frequency of biologicals is more important than the dose, because when you tell the patient that okay, we are planning to put you on biologicals, you have to explain, you have to come weekly or monthly or 2 weekly. That is a very important juncture of discussion, because it's not just for the frequency of him traveling, but also the cost varies. For example, you're telling him that adalimumab will cost this much and then anakinra will cost this much. He might say anakinra, but then you'll have to then tell him that anakinra is a daily dosing, but adalimumab is a 2 weekly dosing or a 4 weekly dosing, right? So dosing frequency is very important. So we just discussed this on the group also a few days back. So yeah, so this is basically from the table that is given in your JIA. These particular dosages numbers are very important, again just because it's a previous year question. DMARD's not so important, again just obviously methotrexate is weekly, others are daily doses. So here biological, so firstly obviously you should know what drug is in which biologicals. Anti-TNF, you have your adalimumab, certolizumab, etanercept, golimumab, and infliximab. All of these are usually monthly except your adalimumab. Apart from this, adalimumab is usually 2 weekly initially. Later, if the patient is has very good response, then you go to 3 to 4 weekly as well. Apart from that, just remember one trick: if something has sept in it, then you give it weekly. For example, etanercept, which is a TNF alpha inhibitor, but that is not given monthly. It is given weekly because it has sept in it. We know that sept is in, I think in Greek or something, 7. uh, yeah, so it's Roman or Greek, it's 7. So that it is basically weekly, right? Etanercept, abatacept, all of these are given weekly. Rilonacept, all of these are given weekly. Then you have IL-1 inhibitor. IL-1 inhibitor, firstly, how to know that it is IL-1? All of these will have ONA or ANA in the name. Anakinra, canakinumab, rilonacept, all of these will have these. In this anakinra, as I told you, is daily dosing. Canakinumab is your monthly dosing or 4 weekly dosing. Rilonacept, sept is weekly dosing. Rituximab, you know that it can be given either weekly, like depends. It depends on the type of dosing. Is not a very specific one. If you are giving it weekly, then you give it for 4 weeks and then you call after few months. Or sometimes what we do is by week 1, week 4, and then 6 monthly. You don't need to remember specifically rituximab how to give it. Depends a lot. Abatacept, again, as I told you, weekly because sept is there. Tocilizumab, it in Sogia, it's given 2 weekly. In systemic GIA, in others, it is given monthly, 4 weekly. Tofacitinib is a daily oral drug. So this is what I had posted. I think a lot of you, saw this particular message as well. So you can just look at this. You can just take a screenshot and keep. So mainly anakinra and the sept concept that you remember. I think that is what will define your answer in most of the MCQs. Now coming to polyarteritis nodosa, again, this is a previous, these two questions, polyarteritis nodosa and Sjogren syndrome, are frankly not so important. So these both are your previous year questions only. These both were actually asked in your older pattern NEET SS when it was 100 questions, not the 150 questions. I think it's something like 2019 or 2018 these questions were asked. So both are fairly simple. If you have gone through the chapter, it's very easy to answer. But yeah, the topics as such frankly are not important. Last few years they've not been asked also, but because it's a PYQ, it's important. So which is not involved in polyarteritis nodosa? From the name itself, just to remember, because this is a very common MCQ in our PG days, as NEET PG days as well. So pulmonary artery not involved. It's there in the name itself. But what else? Firstly, when pulmonary artery is not involved, but importantly, the bronchial artery can be involved. That is one trick that is asked. That can be asked again. Then glomerulonephritis is not there, even though renal artery is involved. So renal artery can be involved, but glomerulonephritis is not there, very rare. But and also pulmonary artery is not involved, but bronchial artery can be involved. These two are very commonly, kind of trickery questions they are put. Apart from that, almost most of the medium vessels as in your mesenteric artery, your renal artery, your coronary arteries, all of these are involved, and these are your usual findings that are there in your polyarteritis nodosa. So you have a lot of aneurysms everywhere. You have skin lesions. What are skin lesions? You can have ulcers, which are the most common skin lesions. You can have livedo reticularis. You can have nodules. You can have gangrenous lesions. All of this. And also another important thing to remember is your mononeuritis multiplex is the most common vasculitis leading to mononeuritis multiplex. And because of this renal artery involvement, it's very common for these patients to have renal artery stenosis causing hypertension. Muscle involvement is not uncommon, it's there, but not a very prominent complaint. Cutaneous, I have told you. Angiographic, I have told you. Obviously, this is a necrotizing vasculitis of medium vessels. And renal involvement, very rarely you can have. Proper glomerulonephritis can be there, especially in children, it can be there, but it is much less common than your proper renal artery involvement. Then you have Sjogren syndrome. So Sjogren syndrome, you have parotitis, which is the most common manifestation. Compared to adults where you have sicca symptoms like your ocular sicca, oral sicca, etc. Here you have proper involvement of the parotid, that is the most common involvement. And apart from that, systemic complications like, lymphoma development or neurological involvement like peripheral neuropathy, they are also more common. Polyarthritis, all of these are more common in your children compared to your adults. But that all that was not asked. The most common symptom was only asked, and the answer is recurrent parotitis. Yeah, so then we come to a PID question, leukocyte adhesion deficiency. So whenever a leukocyte is going to a particular area, like it's invading a particular tissue, it undergoes certain steps, right? So the mnemonic for this is MRSI. So just you can remember it like this, or Mrs. AI also you can remember. So firstly, margination and rolling with selectins, and adhesions with integrins. So that is the main concept here. So initially there is margination and rolling, and each interaction will need a ligand on the leukocyte and a ligand on the endothelial cells, and it's a two-way connection that will happen. So margination and rolling via selectins on the endothelium, that is a vasculature endothelium, with CLL Lewis X glycoprotein on the leukocyte. Very important entity. Remember this CLL Lewis X glycoprotein on the leukocyte. Then the next one is, as I told you, adhesion using integrins. The integrin here is present on the leukocyte. So this particular integrin, CD11 18 integrin, beta integrin, is present on the leukocyte, and there's also a VLA4 integrin. That is not so important. Now, why are these CLL Lewis X and 18 integrin? Because they can be deficient in a lot of times. But remember, this particular one is LAD2 and this particular one is LAD1. That is, if this goes, that is LAD1, and if this goes, then that is LAD2. As simple as that. Only this much you should remember. Diabetes is PCAM. I don't think it's not related to PIDs, directly at all, and you don't need to remember that very much. So LAD1 and LAD2, this is very, very important. So LAD3 is also there. LAD3 is similar to LAD1 only. Here what is happening is there is decreased interaction, defective interaction because of the decreased activation of beta 2 integrin. So here in LAD1 there is decreased amount of beta 2 integrin, while LAD3 there is decreased activation of beta 2 integrin, and leads to decreased interaction also. So LAD1 beta 2 integrin is gone, LAD2 selectin is gone, that is the upper one, first one, margination rolling is gone, LAD3 beta 2 integrin only, but activation defect. So what was asked in the question was, what is the association of LAD2? The answer is Bombay blood group. Again, now this is a very common NEET PG question and can be asked in your NEET SS. I think this was asked in one of the INISS general PEDS questions, and from there we have taken it. So type 2, association with Bombay blood group, short stature and abnormal cognition or intellectual disability. This is kind of specific for LAD2. Both will have neutrophilia. Why is there neutrophilia? Because the body feels that the leukocytes are not there, so the bone marrow keeps producing them, because actually leukocytes are there in the bloodstream, but they're not going into the tissue where they're needed. So as a feedback, leukocytes are produced a lot, and it's a lot actually. It's not like 15,000 or something. It's more than 25 to 30,000, right? That kind of leukocytosis will occur. Type 1 that I told you that it is there in the CD11, CD18 integrin defect. There you have, yeah, this is also a very specific one, that is delayed separation of umbilical cord with gingivitis, periodontal disease. All of this will be there. Both will have neutrophilia, that is not neutropenia, neutrophilia. Now, this is, I think, a little bit of a difficult question. This is something that is being discussed a lot in most of our JIA circles and even your systemic onset JIA circles. HLH is something that is always discussed as a complication of systemic onset JIA. There's a separate lecture also that we discussed in the videos. HLH and mass is always there. But this is a new complication of systemic onset GI, which can be asked going ahead. And there's a recent NEJM article also that has come on GI, a very summarized, very short article. It's not like very complicated or something. It's much smaller than whatever is given in your Nelson also. I'll share that in the group. In that also, in complications of GIA, one thing obviously HLH as we discussed. Other thing is again very common, uveitis. Then you have the third one, important one. Obviously, we're not going into the endocrine things like short stature, all of this were there, but the important ones, the little bit of something that can be debilitating to the patient to a great extent, is your ILD as well, especially in your systemic onset JIA. Interstitial lung disease has come out to be a very important emerging complication, right? So I've summarized this from that particular uh, paragraph only, the article which I'll share. So here what is happening, the main important thing that can be asked, firstly you should know that ILD can happen in systemic onset JIA, and it is a possibly a very debilitating complication. Apart from that, you should know that this happens because of treatment. So systemic onset JIA, what is the main treatment we usually give? IL-1 inhibitors, IL-6 inhibitors like anakinra, tocilizumab. These are along with steroids. So these are the main drugs, right? Those drugs will only those drugs will themselves lead to this lung disease in systemic onset JIA. So that is an important one. Apart from that, there will be erythematous, subacute, acute clubbing will be there, atypical rashes will be there. All of this can be there, and it can lead to a lot of uh, complications as well. But mechanisms and all you don't need to remember. Main thing that you should remember is it can occur as a complication of the treatment itself, and it is associated with systemic onset JIA where clubbing may develop. That's it, you need to remember. So this is again a NEET SS 2025. This is not a 2024 question, can come in 2025 also. Needless to say, this is a very, very important topic, repeated multiple times in your INSS, NEET SS, etc. So here you should understand what are the main treatments that you give before the baby is born and after the baby is born. You know how neonatal SLE happens is basically a passive immunity disorder. That is, it's not like the baby is developing autoimmunity. It's basically the mother producing certain antibodies, those getting transferred into the baby, and those antibodies going and hitting certain organs and causing the disease. It's a passive autoimmunity thing, right? So this is treatment to the mother during pregnancy. So during pregnancy, what will you give to the mother? Firstly, why are you giving? Because the mother has certain risk factors. Maybe a previous child had a congenital heart block, then the mother was worked up, seen to have antiro-antila positivity. It can just be that. Or mother might have SLE, and then one of the echoes showed fetal bradycardia. All of these things may happen, and then you say that the baby is not okay in terms of prognosis, the prognosis is not good, and then you think about treating, right? So sometimes what can happen, there may be first degree heart block in the baby, so you want to prevent progression of heart block. So what are the main things? The most promising thing is not IVIG, it is not steroids, not plasmapheresis. The most promising thing in terms of evidence, the strongest evidence drug, HCQ, is HCQ, and it has been proven in research that it does prevent recurrence. So that is the most promising option, and more than 50% recurrence it prevents. Then other options, plasmapheresis, IVIG, dexamethasone, steroids can be given. They are given. In fact, some trials and some guidelines say that dexamethasone and IVIG should be given whenever there is a first to second degree heart block. But again, it's not based on very strong evidence. Also, you can also consider terbutaline. Terbutaline, when combined with steroids, that can also be there. Then you have, yeah, so salbutamol, terbutaline can also be given. So these are the usual like dosing that is there. I don't think they will ask you, but just in case they ask, it's important. Then when you come to your treatment of the baby once the baby is born, then you can either, if the baby has significant conduction defects, then you can go for cardiac pacing, and you can give beta agonist therapy to increase heart rate, when especially when the heart rate is less than 55-60, in combination with IVIG or corticosteroids. And if there is very severe cardiomyopathy, then you can consider cardiac transplant as well. Now, when you come to the non-cardiac complications like your skin complications, all of these are not very important. You basically treat with conservative management or empirical treatment or topical corticosteroids for your rash. Cytopenias, especially when severe, they may require steroids or IVIG, supportive care, etc. is usually given. Cardiac renal, they are very, very less involved. Cardiac in the sense of the cardiac involvement, apart from, for example, a baby did not have cardiac involvement through his pregnancy. Now, in neonatal lupus, new onset cardiac involvement is very, very rare. So is any lung involvement, renal involvement. These things are rare. So yeah, this is again another PID question, another clinical scenario. So what do you have here? So recurrent pneumonia, lymphadenitis, skin infections. So firstly, age. Whenever you have a PID question, always look at two things that can give you a clue. If it is very early, think something like a combined B plus T cell deficiency. Then you look at the organism. Organism will also give clues. We'll come ahead. We'll talk about this in one of the later questions. But organism will also give you a clue. Then you have certain catch findings. For example, you have retained primary teeth. Then you have job syndrome. Some things like that. For example, you have in this particular thing, what do you have? Abscesses. Abscesses is again a catch finding for a possible chronic granulomatous disease, and sometimes there can be cold abscesses. Cold abscesses, a classic finding for your hyper-IgE syndrome or your job syndrome. We'll come to that ahead. But abscesses, direct thinking, you should always go for chronic granulomatous disease, right? So here, over and above that, it is Staph aureus and Serratia. Both are catalase positive organisms. Even obviously, you might not remember so much micro, but when you read CGT 2 to 3 times, you know that these particular organisms like your Aspergillus, your Burkholderia, Staph aureus, Serratia, these are usually mentioned repeatedly because these are catalase positive organisms. You have family history, needless to say, it is a PID again. Hepatosplenomegaly is there, maybe abscesses are going on there as well. And DHR test reveals absent oxidative burst, right? So now there have been so many clues. Abscess is given, this catalase positive organism is given, and DHR is also given. DHR positive or negative, that also we'll discuss, right? So the most common is asked. So all of these can happen, especially P47 Fox autosomal recessive, X-linked recessive. Both of these can happen, but X-linked is the more common one, and it's basically around about 70 to 30. So this is how oxidative burst happens in a particular macrophage or a neutrophil, and we discuss this in detail. It's usually what we talk as the MSN. If a football fan is there, they would know. So firstly, it is, I'm sorry, I put it in the reverse order. On the left wing is N, center is S, and on the right is M, right? So NADPH oxidase, superoxide dismutase, and myeloperoxidase. So this is how the sequence goes. And if at all the first one, that is NADPH oxidase, is gone, then you call it as a chronic granulomatous disease. So inheritance pattern, as I told you, 30% is this X-linked one, 70% is the X-linked one, and the remaining 30% is your autosomal recessive one. What are the organisms involved? Catalase positive organisms. Staph aureus can be there, Burkholderia can be there, Aspergillus, Chromobacterium, all of these are there, and they can cause these abscess like manifestations in your skin, in your lung, liver, spleen, all of these areas, bone as well. Along with that, there is also excess inflammation. Autoimmune manifestations can be there. Gingivitis can be there. New lymph node suppression, and seborrheic dermatitis of the cells. All of these are there. Now we come to DHR. So this is one of the tests which is kind of weird in that. So usually what do we say when a test is positive? So test is positive means disease is positive, right? But here, what we talk about positivity in the context of NBT-DHR is the presence or absence of a respiratory burst, right? So if respiratory burst is happening, then if that is positive, we say DHR or NBT is positive. If respiratory burst is absent, then we say DHR NBT is absent or negative. So as you can see, respiratory burst being positive is actually a good sign. It's actually good because you want your respiratory burst to happen. So DHR being positive is actually normal, and if DHR is negative, then that is what is disease. So in chronic granulomatous disease, DHR is actually negative, or NBT, nitrobutyroxazolium, or diazoxyribotamine. Both of these are negative. Negative doesn't mean that disease is not there. It means disease is there in this particular context, because negative means respiratory burst is not there. That is an important thing. So this is what Nelson says. It's not given very nicely in your Nelson. It's your text is good, but there's no very nice table, etc. So X-linked around about 70 to 2:1 ratio, you can say, and autosomal recessive is lesser common. So GP91 Fox and P67 Fox. Even if you forget this, just remember X-linked, autosomal recessive, X-linked more than autosomal recessive, right? So 65-35 is the usual ratio. That is their recurrent pyogenic infections with catalase positive, very, very important, absent oxidative bursts leading to failure to kill catalase positive microbes. So again, another question on Kawasaki, because now this time they've asked a little bit of a difficult question. So I expect question on Kawasaki again also, and not a very simple question also, right? So this is about clinical phases, which is wrong is asked. So acute, let's go directly to the phases. So basically we have three phases here: acute febrile, subacute, and your convalescent phase. Convalescent is, as the word suggests, it's when almost the clinical signs have disappeared. It's just our last few weeks of the illness, about 6 to 8 weeks after the onset of illness, and only thing in the convalescent phase is their inflammatory markers. Inflammatory markers have not come down yet. So from the end of clinical symptoms till the inflammatory markers having come down and entire disease getting settled, that is the convalescent phase. Acute phase is the very initial 1 to 2 phase, mainly fever only is there, rest not much. Fever and conjunctivitis, all that crash will be there. Subacute phase, very, very important, mainly because your coronary artery aneurysms develop here, thrombocytosis, desquamation, all of this occurs here. So that is why subacute phase is the most important one. So thrombocytosis occurring in the acute febrile phase is not there. Rest of these are correct. So acute febrile 1 to 2 weeks, subacute 3 weeks, very importantly coronary artery aneurysm. So yeah, so another PID question, and this is one question where you have age as a very important clue. So adolescent PID. So usually adolescent PID, unlikely for it to be a combined B plus T cell disorder. Either it will be a B cell disorder more commonly, or rarely sometimes a single only T cell disorder, right? So you can go back to our PID lectures, you see only B cell, only T cell, combined B plus T cell. That's how we read, right? So usually when the patient presents in adolescence or late school going age, it's usually either a B cell, singular B cell disorder, or only a T cell disorder, isolated B cell or an isolated T cell disorder. So here we have an adolescent boy, 3 to 4 history or year history, maybe like something like 10 years he developed the illness of repeatedly having sinusitis and pneumonia. And another important point, location. As we saw, abscess, gingivitis, these showed CGD. Here you have pneumonia, that is sinusal infection, bronchopulmonary infection, GI lumen infection. These indicate humoral immunity being less. So humoral immunity is again isolated B cell. Can be combined also, but usually isolated B cell will definitely have humoral, and very specifically these sinusal infections will happen. So still he has one episode of diarrhea. See again, so lung and GI tract is involved. To Giardia. Giardia again, very, very like humoral immunity specific, and especially CVID, combined variable immunodeficiency specific. So sinuses, lungs are involved. CBC, liver, renal are initially normal, but immunoglobulin levels are low. So this basically kind of confirms that it's a mainly humoral immunodeficiency. And all of these present quite early. Like SCID, we know that it usually presents like very early in age, especially neonatal age group. X-linked agammaglobulinemia is something that is actually a pure B cell disorder, only humoral immunity. But this also will present as soon as your maternal antibodies wane. When your maternal antibodies will wane approximately around 6 months of age, then the baby's antibodies are not there, and this starts to present around 6 months of age. This will present very, very early. Viscotalrich clinical is only not there, like you don't have any eczema, thrombocytopenia, nothing is mentioned. Immunoglobulins also, it depends, like your IgA, IgE, those are specifically less. So IgM will be elevated, right? So though nothing of that sort is mentioned. So this is wrong. This is wrong because of age. So this is one example of a question where age is giving you a massive clue. And also I told you the organism. For example, shin bacteria. What do you mean by shin? That is your, these ones, your capsulated organism. So if that is there, again, encapsulated organisms, mainly B cells, right? So another thing we discussed was this Giardia. Giardia is also one of the ones that is seen in your CVID or B cell deficiency, because IgA is absent. And among viruses, if you see, your usually viruses are in your T cell deficiency, right? But there are certain viruses like enteroviruses. Again, poliovirus also a parallel to enterovirus. These are usually seen in your B cell deficiency. So even if you don't remember the other things, just remember this particular part. This is the most important part. And whenever they give you a clinical scenario asking, giving a clue for B cell deficiency, only these will be the ones which are given. T cell, don't remember anything specific. Even if you forget all of this, it's okay. Even if Candida, you can remember Th17 cells are usually specific for Candida. Otherwise, not very important. This B cell one is important. And obviously, I told you about CGD, right? Your catalase positive organisms. That is also important. Another thing will come to complement deficiencies, that will come to at the end. That is also important. So these are also Candida, Aspergillus, mucors, catalase positive organisms. All of these are there in your granulocyte deficiency, that is chronic granulomatous disease. So CVID can present adolescent adulthood with these encapsulated organisms, sinopulmonary infections, immunoglobulin levels are reduced to all are reduced, but it's not as bad as your brutal neogamoglobulinemia. It comes a little bit late. SCID presents in infancy. X-linked again will present at around 6 months of age. Male, yeah, male is also there. Here also it's male, but yeah, Bruton's agammaglobulinemia or X-linked agammaglobulinemia. If a female child is given, then you can rule out. Viscott-Aldrich, all of these things are not given. So yeah, so 3-year-old boy presents with a history of abdominal pain, difficulty in walking difficulty, we don't think about neuropathy and all, it just may be due to arthritis. Abnormal findings of blood pressure 120/80, diffuse abdominal tenderness, purpuric rash of hands and ankles, periarticular tenderness. So these both are basically signaling arthritis, and swelling of the ankles. So arthritis, abdominal pain, rash, very, very simple, of the ankles, it is HSP. But what is not seen is thrombocytopenia. You call it as non-thrombocytopenic purpura, because you have a purpura, palpable purpura, which is a vasculitic purpura. And in vasculitis, you expect leukocytosis, thrombocytosis, not thrombocytopenia. If this purpura is happening because of thrombocytopenia, then it can happen, but in obviously in HSP, it's very, very rare. Right, so directly you can go to the classification criteria where you have all of this. Palpable purpura should be must. Again, this is one of the classification criteria. It's not like it has to be fulfilled for diagnosis. According to this EULAR classification criteria, palpable purpura is there, and one out of these four, which includes your biopsy of the affected tissue showing IgA levels, renal involvement in the form of proteinuria, glomerulonephritis, arthritis, and abdominal pain. Needless to discuss it again. So basically, it's very, very, the main concept you can remember is vasculitis generally, whether it be PAN, whether it be HSP, any vasculitis, thrombocytosis, leukocytosis will occur. So again, another PID, this one 5-year-old boy brought in with a history of recurrent skin and respiratory tract infections since infancy. So this is there since infancy. Child gets bruised easily, episodes of bleeding comes. That is, in some way, thrombocytopenia is happening. Silvery hair, light colored skin compared to family members. Again, these are certain specific clues. Whenever you think about them, you should get, certain direct answers, right? Because in no PID do you see these light hair and all, like your major PIDs I'm talking about. Light hair, albinism, and what else is there? You have large eosinophilic granules inside your neutrophils and monocytes. That is your lymphohistiocytosis, mild hepatosplenomegaly. These both are enough. Just the silvery hair and your lymphohistiocytosis is enough to say this is Chediak-Higashi syndrome. So this is a usual, kind of clinical scenario, how it happens. 3-year-old boy with scraped knees, with, severely infected with visible pus, bleeding gums because of thrombocytopenia. Pancytopenia happens, in fact. Then very pale retina, because of which the behind it can appear bluish. Hair is blonde, and some of his parts of hair are silver, and started on your broad spectrum antibiotics. And also there is lymphohistiocytosis that can be seen. It's Chediak-Higashi syndrome. So etiopathogenesis is basically list gene defect. So LIS gene is basically a lysosomal trafficking molecule, lysosomal trafficking regulator gene. So that LIS gene will be mutated, and the pathogen is not very important to understand exactly. What happens is your microtubule function is deranged because of phagolysosome fusion. These both things you can remember, which can help you understand a lot of things. So whenever microtubule is deranged, that means cells are not moving. For along with cells, some particles like melanosomes are not moving. So when melanosomes are not moving, the everything is not able to get pigmented. That is why this albinism is happening. Also, phagolysosome fusion, there is a defect. So because of this defect, there can be lymphohistiocytosis that can occur. Also, there are pancytopenia can occur because of some maybe migration defect of your stem cells that can occur. Right, so inheritance pattern is not very important. Inheritance pattern a lot of times is autosomal recessive. Most of the your most of your PIDs are X-linked recessive. If you look at the generally most of the PIDs are X-linked recessive, including your CGD, SCID, etc. But this one is autosomal recessive. Apart from that, you also have a mnemonic that is plain. So P stands for peripheral neuropathy, or you can say progressive neurodegeneration. L for lymphohistiocytosis, A for albinism, I for recurrent infections that is there. And yeah, so P and N are both for your peripheral neuropathy and your progressive neurodegeneration. So these both are for P and N. L is for lymphohistiocytosis, albinism, and your infections, recurrent infections. So this is your lymphohistiocytosis. Pancytopenia occurs because of which there is a lot of bleeding that is happening here. And eosinophilic peroxidase positive giant granules in your neutrophils and platelets. Yeah, so the CHS1 mutation is also important. So least risk of JIA, least risk of uveitis in JIA. One of the complications which we discussed is your Sjogren and Sjogren-associated ILD and HLH can also occur. So these complications of JIA, all three are very important. Uveitis, ILD, a new emerging serious complication, and your HLH. So least risk of uveitis. So in your Nelson there is a table that is given, which is not, it's okay, but it's very complicatedly given and it's not very important. What you should mainly remember is what are the risk factors of uveitis in GIA, right? So this is, so again, why I say this is not important. Firstly, it's never been asked, the length of screening and all, it's never been asked. Secondly, there are multiple recommendations for that. So this is one of the British recommendations, and there can be other recommendations according to EULAR, ACR, etc. Right? So you don't need to remember all of these length of screening. What you should remember is when to screen and what type to screen. Firstly, if it is your RF positive polyarticular GIA or systemic onset GIA, these have a very low risk, while the others, like oligoarticular, polyarticular, psoriatic arthritis GIA, and others are at a higher risk. What happens with enthesitis related arthritis is kind of interesting, because why are we screening in other patients is usually uveitis will be subclinical or it will not present with this redness, etc. Here it presents as acute and symptomatic red uveitis, right? So because it is acute and symptomatic, you don't screen very often. It's not like uveitis is not very common here, but the screening is less. So why I'm telling you this is mainly if they ask you which has to be screened at the highest frequency, they can ask that particular thing at the highest frequency, then you prefer these things. That is the first point. Second point is what are the risk factors, other risk factors apart from the type. So then you have, just imagine a young female with ANA positivity, recently developed GIA. So just imagine this, and she is someone who is at the maximum risk. What do you mean? That is young. If it was an older patient, for example, age at GIA onset, if it is an older patient, then you have lesser risk. If it is less than 6 years, more risk. More than 6 years, higher risk. That is it should be young. The patient should be young. And next, if it is a male, then you have a lesser risk. If it is a female, then you have a higher risk. Then ANA positivity predisposes to high risk of GIA. And lastly, recent is your GIA duration. If the GIA duration is less, near to your presentation, then also that's a higher risk. So this is one particular scenario which you should imagine. What are the the highest risks of GIA? So among this, what are there? RF positive polyarticular GIA. As I told you, types is important. RF positive and SOGIA, these are the lowest risk. Again, the third complication, we talked about ILD, we talked about uveitis. Now we come to the third complication, that is HLH, again seen in mass. So what is happening here is your NK cells, T cells, all of these cytotoxic cells release a lot of cytokines. It can be IL-1, it can be IL-6, it can be gamma interferon. All of these go bring a lot of neutrophils, cause cytokine storm, cause your SIRS, cause a lot of systemic inflammation, tissue infiltration, organ damage. This is what is happening. But what is more important is your treatment agents. As I already told you, high dose steroids, pulse steroids can be given, IL-1, IL-6 inhibitors can be given. But what is more important is the new drug, and that is imapalumab. So imapalumab is a very important upcoming new drug that has been recommended already in treating your HLH, HLH or mass associated with your systemic onset GIA. But what is the mechanism of action? Again, this is given in your Nelson. This is not some high level update. This is from your Nelson image only. So it is important to remember, especially because over and above that, it's being discussed a lot. So this is important. So emapalumab is interferon gamma antagonist. So even it recognizes free interferon as well as interferon boundary receptor. Is interferon gamma antagonist. It's fully human IgG binding. It's a monoclonal antibody against human gamma interferon. That's all you need to remember. And it's used in systemic onset JIA when there is HLH. IL-17. So this is an immunology question, and I think in immunology, I think this is the only question that is asked here and there from this particular area. This is the main image that you need to remember. That is, this is the differentiation of TH cells. TH cells can differentiate into TH1, TH2, TH17, and there are multiple more also, T regulatory cells, T follicular helper cells, etc. Main thing that you should remember is these three. These three you just remember. T regulatory, no need to remember, just remember IL-10 is released by T regulatory cell, and that is the IL-10 attenuates immune response. That one thing you can remember. But what is more important is what do TH1, TH2, TH17 release. So firstly, these is the most important part. What do they release? Then you can remember, maybe you can remember what are they stimulated by, right? So what does TH1 release is IL-2 gamma interferon. Both will, IL-2 will go and increase your T cell activation, gamma interferon will go and increase your macrophage activation, form granulomas, etc. Right? So that is activating macrophages and cytotoxic T cells. TH2 mainly is releasing IL-2, IL-4, IL-5, IL-13, and this will activate eosinophils. IL-4 and IL-5 mainly activating eosinophils, and IL-10 a little bit. Forget this IL-13 and all. Sorry, IL-13 you remember. IL-6 is not very important. So IL-4, IL-5, IL-13, and a little bit of IL-10. IL-10, why is it important? Because it attenuates inflammation. So that is also important, released by TH2 as well as T regulatory cells. TH17, only two things, IL-17, IL-22. That was the question, and I think it was not very difficult per se. Even if you just remember this image, I think in immunology, if you're not able to read anything, then just remember this image and go, right? Because this is the most important part. After this particular area, after this what is secreted area, this is important. So in that also, mainly TH1 and TH2, they may ask. TH1 is increased by IL-12 and gamma interferon. It releases gamma interferon and IL-2, while it is stimulated by IL-12 and gamma interferon. IL-2 and IL-4 stimulated, while it doesn't release IL-2, it releases IL-4, IL-5, IL-13, and a little bit of IL-10. And TH17, I don't think you need to remember this one, right? Then this was again one of the difficult questions, I would say. If you have read Nelson Immunology very well, then you may answer. But I think this was a previous INI question. Now we don't know if that INI question was from general peds or rheumat. So that's why I would say take this question with a pinch of salt, because if it came in general, then it's important to remember, because it can also help you get that edge, because others may not be able to answer this, right? So 4-year-old child presents with chronic persistent lymphadenopathy. First thing, hepatosplenomegaly. History of recurrent episodes of AIHA and thrombocytopenia, that is autoimmune cytopenias are happening, that is third. Then you have increased serum IgA and IgG. That is, it's not a PID, it's a dysregulation disorder. It's an immune dysregulation that is happening. So firstly, you can rule out this. As soon as you see, you can rule out this and this. So you just, the main thing is confusion between ALPS and XLPS. Flow cytometry showed double negative T cell. Now, if you have read only, you can answer this. If you have not read, you can just mark something and go to the next question. So, what is just to remember, what is happening is in ALPS, it is basically like an autoimmune storm. It's like everything is autoimmune. Everything in autoimmunity is happening. Autoimmune cytopenias are happening, lymphadenopathy, hepatosplenomegaly, fever, and everything that can happen in autoimmunity like lymphoproliferation, hypergammaglobulinemia, urticaria, uveitis, hepatitis, all kinds of itis will basically happen in your autoimmune lymphoproliferative syndrome. Now, why is this happening? Because it's a kind of apoptosis defect. So A for A, apoptosis fast cell. If you remember something from Robbins, it causes apoptosis, right? So apoptosis defects of a lymphocytes are increasing, and those lymphocytes are causing an autoimmune storm. It can cause various types of autoimmunity, usually presents the first year of life, symptomatic by age 5. The main thing that you should remember is this double negative lymphocytes, CD4 CD8 negative lymphocytes are seen, and TNF alpha receptor gene defect is usually occurring. Treatment, you basically try to do a bone marrow transplant. That is the best treatment. Sirolimus and all, tacrolimus, sirolimus, rapamycin, all of these are just temporary measures to suppress autoimmunity, but mainly you would go for your main treatment, that is stem cell transplant. XLPS, the only thing that you should remember is it is causing, it's a predisposing factor to HLH in caused by EBV, right? So whenever there is HLH, you have to do a genetic workup. The HLH is hemophagocytic lymphohistiocytosis. You have to do a genetic workup, and there are certain genetic risk factors for HLH, and one of the things is your XLPS. And also this can lead to lymphoproliferation is there, so lymphoma risk is also there. So this is one of the causes for primary HLH. Just remember that much, right? No need to remember more. Then you have another, so I was discussing job syndrome or hyper-IgE syndrome. So this is one of the important ones, important PIDs. And I think some of you were messaging me also asking a session on hyper-IgE syndrome, but that is already given in your PIDs video, right? So recurrent skin abscesses described as cold staphylococcal abscesses, recurrent pneumonias, coarse facial features, retained primary teeth. Retained primary teeth is said as baby teeth did not fall out recently. Broad nasal bridge, normal coarse faces is there. Eczema, scoliosis, very important, and retained primary incisor. And this shows a hyper increased eosinophils and increased IgE levels. Right. So this is a STAT3 gene mutation that is usually occurring, right? So this is how the boy presents with a broad nasal bridge, retained primary teeth, eczema, all of these are there, and high increased IgE levels, right? So it's also called HIES, hyper-IgE syndrome. Pathophysiology is not required, but mutation is important. It's a STAT3 mutation. That was the question that was asked. What do you see in lab findings? You basically see increased IgE levels, and also you see gamma interferon to be decreased. So gamma interferon to be decreased, IgE will be increased, and also eosinophils will be increased, right? So what is the mnemonic here? It is fated. So for F, you can put two things: coarse facies, that is facies, and fractures. Fractures are very, very common with mild uh, trauma. This is abscesses, cold staphylococcus abscesses. T is for teeth, E is for IgE, hyper-IgE syndrome, and D is for, or you can say E is for eczema and D is nothing. And anyway, you can say D is for dermatological complications, that is your eczema, right? This is your mnemonic, that is fated. And also remember water. Don't confuse this with water. Water is for your Viscott-Aldrich syndrome. Water, you have IgA, IgE, both of these are decreased. Then you have your Viscott-Aldrich, you have your Viscott-Aldrich syndrome, you have thrombocytopenia, eczema, as well as your recurrent infections. That is what is your Viscott-Aldrich syndrome. Yeah, so this is again one of the, again coming back to proper rheumatology, JDM is an important topic actually, but recently last 2 years or so questions are being asked less. But yeah, so all of the following are more in your JDM compared to adult counterpart except. So this is a very important concept. I've put this in I've made a small, emoji filled message, and I keep putting that in our group also. So compared to adult onset, calcinosis, something like vasculopathy. Vasculopathy is more in your juvenile. So vasculopathy will cause lipodystrophy, will cause calcinosis cutis indirectly. So even if you just remember vasculopathy, and that can cause abnormal small skin changes like calcinosis cutis, lipodystrophy, that much is enough. Those are the things that are more in your juvenile. Other complicated things, so local small skin things, are more in your child, while in your adult it is the dangerous things like your malignancy, ILD, and cardiac disease. That is the thing that you should remember. Malignancy can occur in both, but considerably more in your adult after 40-45 age group. Calcinosis cutis obviously more in your JDM compared to your adult. Lipodystrophy more, vasculopathy more. Finally, I told you about complement deficiency. You just need to remember one table. Mainly also in that also, I think you would remember this from very commonly asked NEET SS questions. If it is late complement deficiency, C5 to C9, it's usually Neisseria infections, gonococcal infections, etc. If it is early complement deficiency, it is SLE. So, except is asked here. So, C1 esterase inhibitor, needless to say, very commonly asked hereditary angioedema, and C1q early complement SLE, and atypical HUS from your nephrology, you remember factor H. C4 DLE or discoid lupus, there's nothing specific like that, right? So C3 deficiencies, C1q deficiency, C2, C4 for SLE. Also early complement deficiency, especially your C3 deficiency, can lead to your recurrent pyogenic sepsis by your encapsulated organisms. Propyridine D encapsulated, this is not very important. The main thing is factor H, factor I, atypical HUS, C1 esterase inhibitor deficiency, angioedema, CD59, your DAF, MERL, etc. is for your paroxysmal nocturnal hemoglobinuria. C5 to C9 deficiency is your Neisseria. So these are your important things that you should know. Yeah, so with that we complete our first elite. We will be doing, I think, around 12 elites weekly. Next would be pediatric hematology oncology. Do give us feedback about, you want the questions to be a little bit tougher, you want them to be easier. You can message us on the WhatsApp group, or you can message us directly, or you can even, I think that would be the best one, because sometimes the comments under the YouTube video or the video per se might get missed. So best thing is you can directly message us, and any doubts also you can directly message us on the group itself.
Recording stopped.